Welcome to the Neuroveda podcast for complex health. We feature expert guests who dive into ancient and cutting-edge understandings of health and disease. These conversations are about food, lifestyle, and medicine just as much as they are about nature, culture, and politics. I'm Gillian Ehrlich, family nurse practitioner, certified in Ayurveda and functional medicine, coming to you from our clinic, Neuroveda Health, in Seattle, Washington. And I'm pretty excited. We have a very interesting guest today. We are joined by Dr. Jon Berner. He is a Harvard-trained psychologist, a UCLA-trained neuroscientist and physician, and a University of Washington-trained psychiatrist. With over 25 years in clinical practice, his work bridges rigorous neuroscience, psychiatry, and compassionate patient care. Dr. Berner's publications span from the cognitive effects of cocaine in memory and schizophrenia to pioneering treatments with ketamine, rapamycin, and novel metabolomic approaches for mood and pain disorders. He brings a unique lens, uniting neural networks, biochemistry, and clinical psychiatry to reimagine how we treat complex mental health conditions with both precision and humanity. Dr. Berner, welcome. Happy to have you here today.
Thank you.
So, this show, as you and I were talking about kind of what we wanted to talk about and how we were going to approach this, I love your metabolomic sort of like chemistry, science-driven approach to mental health. And so I'm wondering if you can talk to us a little bit, if we think of this as a mind-body medicine show, um, what really comes after we think of the name mind-body medicine? Like we've been stuck in silos. What does the alternative look like, specifically anchored from a psychiatry perspective? If we're not separating the mind and the body, if we're not separating out into rheumatology and now here's neurology and here's the cells of the anatomy of the brain and here's the cells of the immune system, what is the alternative?
Um, there's lots of ways to think about this, but maybe one way that would be interesting is to think about the distinction between classical physics and quantum mechanics.
Mhm.
So before, let's say, 1930, we lived in a Newtonian world where we looked at things in physics that were large, you know, bodies falling through space, planets circling around the world. And everything was deterministic. You could do equations and you knew exactly what the world was. And that was Newtonian physics, right? And to some degree, you can make this terribly rough metaphor with what happens in the anatomy lab when you're a first year student in medicine or nursing or dentistry, and you're opening up the body and you see these organs and they're distinct, right? There's a liver, there's a brain, there's a spinal cord, there's a muscle, and there are names for them. Everything is deterministic, and it never changes, right? Anatomy is the same in the 1400s as it is in 2025. And that's the Newtonian world, where things are concrete and predictable. And then suddenly, in the 30s or whenever it was exactly, quantum mechanics came out, and things were probabilistic. And particles could be at one place and another at the same time. And in order to measure phenomenon that you were interested in, you had to invent these new technologies that measured things at tiny, tiny timescales and very, very fast. And this concept of the Heisenberg uncertainty principle came up, that the very act of measuring what you were interested in changed what you were interested in. And so you couldn't both know the velocity and the location of a particle at the same time, right?
Mhm.
And I think now in medicine, we're in the quantum world, right? Where it's really not very interesting anymore to talk about brain disease or liver disease or blood disease. It's kind of boring, right? What we're talking about is the quantum world, which is this world of a cell talking to its neighbor with a language that is very local. And we have to eavesdrop on this language somehow without disturbing these cells that we're interested in studying. And the tokens that these cells talk to each other with are things like inflammatory cytokines, tumor necrosis factor alpha, Things like metabolites. So some of the ways that cells talk to each other is they look to see, oh, how much serotonin is available, how much tryptophan is available, and cells communicate with each other by breaking down certain proteins in the local environment. And so you can kind of poison your neighbor if you want to, by breaking down one of its metabolites it needs to grow or to divide, right? And these cells are talking to each other, and they're sort of like a native Inuit tribe, saying, hey, grandma's too old, let's leave her on the ice floe. And grandma's like, yeah, I gotta go. I want my grandkids to survive. So I just go quietly to the ice floe and I don't make a lot of noise because that's what I need to do in order for the tribe to survive. Right. So a lot of biology may be incredibly local,
Mhm.
right? And the language that you're born with as an individual in the way that your cells talk to each other maybe slightly different than the language of your sister and the language of your mother and the language of your daughter or your son. In other words, we have genetic variations in that language, a personal dialect, in the way that our cells talk to each other. And somehow now as physicians, we have to figure out, well, how can we help these cells communicate more clearly, right? So that as our cells get old in our body, they die quietly. Or that as our cells get old in our body, we have a fresh, young, healthy population of stem cells to replace those old cells, right? And boy, this is not what you discuss in medical school. And it's certainly not what you see in a lot of the YouTube videos where everything is described in terms of a single pathway or a single metabolite or a single drug. This is a conversation between cells that has a quantum-like probability. In other words, it's not just one metabolite that determines whether a cell decides to die, or whether a cell decides to grow, or whether a cell decides to specialize a lot or specialize a little. It's a whole integration of the local microenvironment, that tells it what to do. So the mind-body problem is kind of not even the right question, right? It's more like, hey, what is going on in my local community? It's all community. What are the conversations going on between the cells in my brain? And that's where we're at. And of course, the problem that you and I talked about, if I can jump ahead, is how do we measure this?
Yeah. When I was starting to do more and more kind of neuroimmune access medicine, we do autonomic testing for dysautonomias or POTS in our clinic. And when I started really probably in the last 5 years, 5 to 8 years, looking at mast cells and mast cell activation, I started thinking more and more and more about the degree of cellular communication that happens in our system. And I happened to be at one point, I was watching a Mariners game sitting in the stands. And I remember looking at a sea of, I'm going to get this number wrong, 56,000 people, let's say. And I remember thinking, this is what it's like in the human body. Like all of these people have kind of a central sense, like the cell itself has directions for its behavior, for DNA to translation into RNA, which is then producing proteins, which is then having all of its activities within its membrane and then communicating it along its membranes. But it's like there are things that are global, like when the Mariners hit a home run, or the other team or something on the field that drives so much that commands so much of the attention of these 56,000 individuals. But then there's always like a beer being spilled in this aisle or a baby's diaper being changed in this aisle. So then there's this like mix between of awareness or communication or something between what what commands the attention of like a lot of the cells and then what becomes a localized environment.
I love it. I love it. I think it's perfect. If you want to think about it in a different way, again, I think you and I are on the same intuitive page, right, on this.
I think so too. Yeah.
But
Yeah.
in programming, you have the distinction between a global variable and a local variable.
Hmm.
Right? They give it almost the same name, but you want this sort of variable that all the software uses, and then occasionally you want to tweak it, but just in a very local situation.
Hmm.
And that's a great way to get your program to crash. Use the global versus the local variables,
Interesting.
right? And then we think about what does the endocrine system do? By definition, the endocrine system is one of the control functions that coordinates local information, right? So,
Oh, interesting.
when you think about what does insulin do, right? Insulin is a signal to every cell in the body
Hmm.
that you're in a position of nutrient excess, right? So it says, oh, it's okay now, right, to grow,
Hmm.
because there's enough food out there that you
Hmm.
can grow, and you can stop doing autophagy because it's not necessary. You can get all the amino acids and carbon building blocks from the extracellular environment, and you don't need to use autophagy to generate building blocks from within the cell. So insulin is one of these great control molecules that bridges between the external environment and the internal environment, the global and the local, right? Same thing is true of cortisol, right? Same thing is true probably of sex hormones, thyroid. This is why maybe again I'm being metaphorical, and I hope our listeners will forgive us for this, which is and this is why there's this intuition. It's my hormones.
Hmm.
Why people have this just deep intuition that it's something to do with my hormones. Why are they more special than everything else rather than sodium? Because people understand in an intuitive way, right? That these are the bridle on the horse, and I might be able to affect a lot of the cells in my body all at once, right? I'm not going to nickel and dime it if I'm feeling well with a drug that just affects the brain, right? Or I'm not going to nickel and dime it with a drug that just affects the skin. There's this fantasy like, oh, if I fix my hormones, I could really hit a home run.
Hmm.
I could
Yeah.
be amazingly better, right? Not just a little better, right?
Yes.
And so then the providers get into this gambling fallacy where, I'm making up a number. 1 out of 10 patients, you mess with their thyroid and they're just amazingly better. Or 1 out of 10 people, you mess with their cortisol, they're amazingly better. And if you're not disciplined, you start thinking like a gambler, like, oh, it's all cortisol, or it's all thyroid.
Hmm.
And that's probably an intellectual mistake, but it's not an intellectual mistake, maybe, to think that the concept of central coordination is very important.
So this is not something that is like answerable, but I'm just curious for you to weigh in with your opinion. Um, Nothing wrong in a podcast. We can say anything we want here. I'm just curious, do you think, what percentage of like the mind body complex of our human being, what percentage of the activity or energy do you think goes towards communication and instructions versus what percentage goes actually towards cells? And I'm
Okay. So, I mean, are there energetic constraints in terms of the cell's ability to talk to each other? Is that what you mean by that? Or
or like are we because I think that um we think of ourselves as we think of ourselves as a person in a body, right? And we
well,
think
are
we are.
how that hurt to me.
But I think that we're trained in kind of this reductionist, which was Newtonian way of like we are built of tiny cells, we are built of tiny bricks, and these bricks go together, and then these bricks move through space. And then maybe there's a little bit of a spirit or a soul that kind of sits in there somewhere, wherever that sits. But what you and I are talking about is that there's a high percentage of or higher than I think previously anticipated percentage of the body that actually gets energy and cells devoted to the communication pieces, um, and to the instructions. And, in terms of like our hormones and our cytokines and our nerve signals, like it's a kind of a weird question to say what percentage goes where, but I'm just curious, like, are we, do you think of us as like, because I feel like the way that I was trained in nurse practitioner school and just in science, I would think we would be like 96% bricks, build it, to sell bricks. And then like, maybe we're just like 2, 3% of this communication. But the older that I've gotten and the further that I've gotten into medicine, the more I realize I think it's a much larger percentage of the body's energy and structure and function is actually devoted to cellular communication, sensing, processing, and behaving versus like giving instructions or communicating versus just the actual building blocks of a bone, a muscle, a knee, an ankle. Does that make sense?
I think I'm trying to parse what you're thinking about as you describe this, because you have an intuition there's something that needs to be elaborated on, and I'm trying to follow your thinking on this. I'm not happy with this idea of drawing cutoffs, right?
Yeah.
This is kind of one of the errors of internal medicine that you see all the time. Well, if your blood sugar is 100, you're pre-diabetic, but if it's 99, you're fine,
Yep.
right? Right? These cutoffs, right? Like, oh, you have Alzheimer's if you've got, 15% of your brain lights up with plaque, but if it's 14%, you're fine. I mean, these are completely arbitrary. They mean nothing. It's a intellectual error to think of biology as being a binary process. You have a disease or you don't.
Mhm.
All of us have cancer right now. All of us
Mhm.
have very much, hopefully, right?
Right. Right.
All of us have stress from too much insulin, a big Thanksgiving meal where our pancreas just went crazy producing enough insulin to pull the sugar into the fat cells in the liver and the muscle. And then inadvertently, we caused other cells in the body to grow too much. And that actually damaged them.
Mhm.
Caused a trace of oxidative damage and DNA damage. And so we're all type 2 diabetic, to
Mhm.
some degree, right? And so it's just so dangerous to think in a Boolean way. And it almost always means you haven't thought clearly about what it is you're trying to consider, right? Um, the way that I'm parsing the question is, what are the fundamental constraints on being healthy?
Mhm.
What are the fundamental that we can't, they're like gravity, right? We can't ignore,
Mhm.
right? And those are going to determine how our cells talk to each other, right? And the obvious is starvation, obvious, right? I mean, there's this great story that's too good to check that like 25% of Army recruits in 1941 were turned away because they were malnourished
Wow.
around the Great Depression, right? I mean, it's a blink of an eye in evolutionary history to where we had enough food, right?
Mhm.
Like a feast. Remember the concept of a feast, right? People had loved to feast because they could actually eat. I mean,
Yeah.
but we have a feast every day in this country. I mean, you can have a feast every day.
Yep.
That in the 1930s would have been like, oh my God, that person's rich, right?
Yeah.
So starvation is this absolutely fundamental global constraint
Mhm.
on biology.
Mhm.
And we've evolved since the vents, in order to manage food availability. food loss. And of course, now we're being poisoned by too much food, which is a great thing, right? There's no morality to it. It's just reality. We have more food than we need, and it's delicious. So that's one constraint. What's another constraint? Infection, right? I mean, TB still kills 1.5 million people a year.
Yeah.
I mean, still, right? And it was not uncommon until very recently, for your siblings to die from, you know, poor sanitation and waterborne disease. You know, gut immunity had to be highly optimized if you and your family were to live.
Mm-hmm.
Have refrigeration, it wasn't easy to wash your hands. People
Mm-hmm.
died all the time 100 years ago from foodborne disease. Women died in childbirth from infection. I mean, people just died, right? And so
Mm-hmm.
it's not surprising that there's a group of people whose parents and grandparents and great grandparents survived the plague and syphilis and typhoid and blah, 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 blah. And now they're hyper optimized to kill infection, but their immune system is like a nuclear bomb. I mean, it just kills everything.
Mm-hmm.
So that's another fundamental constraint is infection. I think things that psychiatrists think a lot about in terms of the mind-body issue is predation. We live in this world of relative safety where, war is not killing people.
Mm-hmm.
And to some degree, crime is under control, right? But that's a new evolutionary event, right? So if you look at the X chromosome in Colombia, or the Y chromosome in Colombia, and the Y chromosome in certain parts of Spain, there's absolutely no indigenous Y chromosome.
Really?
Invaders came in and they killed every male in that geographic
Wow.
society within a period of 100 years. They either
Wow.
killed them or they outcompeted them for mates.
Mm-hmm.
And I think this is a problem that you see when you think about the mind body problem, is this sort of, I'm actually using this very specifically, this feminine belief that compromise is possible.
Mm-hmm.
That's just factually inadequate,
Mm-hmm.
right? Sometimes you must go to war. Otherwise, your Y chromosome will die. Right? And so the issue of predation trade-offs, right? Social status, our biggest competitors genetically are our peers,
Yep.
not lions, right?
Right.
It's it's
Not
it's
sharks,
you're right. It's
not
the
spiders.
tribe next door that will kill everyone,
Mm-hmm.
right? Or at the minimum, kill your sons,
Mm-hmm.
right? So that's still there. It still drives what we do. We pretend we have control over it. Of course, biology laughs, right? We were born to be warriors
Mm-hmm.
and born to fight for social status, uh, even unconsciously. I mean, because we're self-organized, right? We pretend we're conscious individuals. We're only partially conscious.
Mm-hmm.
So, that's part of it. And then, environmental toxins, sunlight,
Oh, yeah.
Caucasian versus dark skinned. I mean, that alone is just so obvious. It's obvious to everybody, right? DNA damage from sun,
Mm-hmm.
right? DNA damage from charcoal,
Mm-hmm.
right? We started cooking 100,000 years ago, right? And so now we're getting all of these charcoal-like products that are going through our liver and presumably causing DNA damage. And I would bet you $1 to whatever that our liver has mutated quite a bit in the last 100,000 years. in response to cooking, since we see a lot more cooking byproducts. And does that affect things like gut immunity, gut health? That's a remnant of I mean, cooking's fantastic, right? It fixes the starvation problem. Remember, this is all trade-offs, right? It fixes the starvation problem. Because now we get twice as much food per unit of carbon because we break it down better, but it causes a different problem, which is the free radical DNA damage from heat byproducts. Right? And so there's probably a few other major ones, but I think that's how I'm sort of approaching this concept, right? But I don't think it's an energetic issue in terms of cells communicating with each other. I think it's that these large evolutionary things compete against each other, right? So you can be really fat and survive a volcano or an asteroid strike, but you're not going to do very well at 105 degrees on the high plains of Africa, where you have to sweat 3 liters an hour in order to be a persistence predator or a persistence scavenger.
Mm-hmm.
It's just really hard to be a generalist. Everything competes against each other.
And so how does that, like, taking that approach, how do you as a psychiatrist use that when you see patients?
Well, I think this is this concept of intersectionality,
Mm-hmm.
right? That we're trained because we're students and we're stupid, right? And that's not meant to be to denigrate, it's meant to be humorous, right? We really are stupid, right? You go into your training like really nervous and you realize you don't know a damn thing, and
Yep.
are your patients going to say you're a fraud? I mean, literally, you don't know anything.
Yep.
Just walk out the door, right? They've
Yep.
recognized who you are, right? Which is a fraud, right?
Right. Right.
But you have all these wonderful checklists and these books, and they create this illusion of simplicity. Oh, I scored 25 on a PHQ-9 score for depression, which is, between 1 and 27. I have depression, right? So, but you realize really quickly in clinical practice that these are extremely broad categories,
Mm-hmm.
right? And that one person with a PHQ-9 score of 25 may have almost no biochemical overlaps with somebody else with a PHQ-9 score.
That's exactly right. Yep.
And so you have to look for intersectionalities in the clinical presentation. In other words, is somebody who's very, very heavy, but has insulin resistance, different than somebody who's very, very heavy and who doesn't have insulin resistance? In other words, do you treat the depression differently in those two people? You're doing intersectionality, right?
Mm-hmm.
It's
Right.
it's a location in a landscape of evolutionary trade-offs.
Yep.
And so and of course there is data on this, right?
Mm-hmm.
Like I think there was a conference a little while ago, and someone was showing me some data on the GLP-1s, Ozempic and those sorts of drugs. And they said, hey, look, if you got metabolic syndrome and you're heavy and you lose 15 pounds, your PHQ-9 score goes down by 3 or 4 points, let's say 10 to 15%. But if you're an anti-diabetic, obese without metabolic stress, it doesn't change it at all. You don't get less depressed, right? So there's this always sort of psychological hypothesis, like, oh, if I'm skinnier, I'll be happier. Whereas glib, not evidence-based, right? In the intersectionality world, it may be true as a provider. You can say, hey, look, you're not insulin resistant. I know you want to lose weight, and a healthy vanity is fantastic, and there's reasons to lose weight, but it's not statistically likely you're going to be happier.
Right.
I mean, I think that's a valuable bit of information, right?
Mm-hmm. Mm-hmm.
Are there other intersectionalities that you use in psychiatric medicine? Of course. I mean, all the time, right? I mean, you're depressed and you've got an autoimmune disease. Oh, yeah. I mean, you got fibromyalgia. That's an entirely different treatment program, than someone that doesn't have an autoimmune disease.
Mhm. Mhm.
The, the cellular communication on a local basis is different in those individuals than somebody that doesn't have an autoimmune. Yeah.
One of the things you said earlier in the show already really kind of piqued my interest. The idea that we don't need to do autophagy because we actually don't need to pull nutrients. Like the trash can just pile up because we don't need to recycle anything because there's so many new nutrients coming in.
Yeah, that's really lovely, isn't it? Yeah.
That was really interesting because, one of the drugs that, I read in your bio, and one of the drugs that we are starting to use that I'm seeing you using with patients that we share is rapamycin or sirolimus. Can you talk a little bit about its like mechanism of action and how you're using it and kind of especially in this mental health world?
Sure. I mean, so for people who are not familiar with um, rapamycin is the rage in medicine these days
Yes.
because the animal data is completely consistent that if you give animals rapamycin, in general, they live about 10 to 15% longer. And that goes from fruit flies to mice to simple primates. And we haven't done the human studies very well yet, but it's very encouraging that in a population, it's going to increase lifespan.
Mhm.
And so, boy, this is the holy grail. We have a drug that is, so-called safe, you know, let alone just lifespan. I mean, who wouldn't want to give a patient a drug that might make them live longer? I mean, it seems like theft almost to some degree. It's so attractive.
Yes. Yep.
And so, rapamycin was discovered as an antibiotic produced by bacteria in Easter Island, Rapa Nui, right? So, and then through a beautiful bunch of accidents, they found that at high doses, it very specifically suppressed the anti-cancer immune system at high doses, and so allowed people to have pretty much normal lives who have kidney transplants and lung transplants and liver transplants. And it's a very specific suppression of the immune system. In other words, most of these folks who are immunosuppressed are not dropping dead from bacterial infections, and they're not dropping dead from viral infections. It's just this 3 or 4 pound or 10 pound foreign tissue that they develop a tolerance to, and they live pretty much a normal life. I mean, these are really breakthrough medications.
Mhm.
And then the basic scientists started to look at this and go, hey, if we gave lower dosages, you know, what happens over a lifetime and these animals live longer. And so now we have this clue. We have a clue that there's something important here, right? So what rapamycin does is it binds a molecular chaperone, and a chaperone is, I think it's FKB12, if I recall.
Mhm.
Chaperones are proteins that allow other proteins to fold. So a protein comes out of the cell as a linear strand, but it can't do anything as a linear strand. It has to have an origami moment and turn into whatever tool you want it to become. And so these chaperone proteins that help it fold in the right way. And so rapamycin makes it hard for this protein complex called mTORC1 to fold appropriately, and it doesn't work as well. Okay. And mTORC1 is one of these sort of master control proteins in the body that monitors the internal metabolic environment. Okay? And so it has three things that it monitors. It monitors the availability of local amino acids. It monitors the availability of the energy molecule ATP, and it looks for whether or not there's a growth signal coming from the external environment. So it's an integrator. It's not just a simple protein. It has to have all three things happening at once. So what happens is if there's enough protein and there's enough energy and there's a signal from the external environment that says grow, then the cell moves from being a stem cell into an adolescent. It leaves the stem cell compartment and becomes a young man or a young woman with a beautiful career in front of them. It doesn't make them an adult, though. TORC1 alone isn't enough to make a cell become completely everything it can be. It gets them part of the way there. Okay. So when TORC1 gets activated, cells grow more. When TORC1 gets knocked out, cells don't transition from the stem cell into the adolescent cell as quickly, right? And so you're never like completely blocking it, other your patients die. You're just changing the transition probabilities, right? So that goes back, again, I'm trying to get the intuition in people's minds. This isn't Newtonian physics. This is a probability distribution, right? Just you grow a little bit more slowly and a little less quickly, right? That's what blocking TORC1 does with in the cell. So, it may be the distinction to some degree in a very important way between why the hell are you and I starting our medical practice at age 27 or 32? Why aren't we growing our families at 14, right? Delayed brain development in adolescence, which is, really rare in the animal world. Why does it take so long to get our brains fully developed? Right? Versus a horse that gets up and starts running around in 6 hours, right? So it goes back to this trade-offs, right? Super interesting, right?
It is.
To some degree, by definition, is the human mTORC1 complex downregulated a little bit relative to mice and to dogs because it takes us so long to become human. Right? And then what does that mean in terms of applying animal literature or rat literature to humans? We don't know, but it's just remembering we're not the same as rats and we're not the same as monkeys. We're different.
Yep.
Even in this few million years of development, we're different critters.
Yep.
Right. Anyway, so RAPA. So what does that do? Well, it gives us a way to stop cells from growing too fast. Right. And where is that a problem? Well, where do we need to grow cells really quickly? The immune system. Right? So the immune system, because we've survived all these urban diseases, in a substantial number of people is hyper optimized. Right? The cells grow so fast they kill themselves. Or they grow so quickly that they age too quickly. And this is something called the exhausted T cell that the cancer biologists know very well. Where a cell, if it gets too much external stimulation, it doesn't last very long. It fights the infection for 8 hours and then it kills itself. It fights the infection, the cancer for 8 hours and then it becomes quiescent. It doesn't just stay there young and healthy and just, sort of whacking away at the opponents for days and months. It prematurely ages. And so is there a group of humans, to some degree, just randomly inherited from their mom and dad, a deck of cards where their cells grow too quickly in response to these central growth signals from the environment? Things like insulin, things like sex hormones, Things like broad scale systemic infection, that are a signal to the immune cells, grow as fast as you can.
Mm-hmm.
So you can think of rapamycin at low doses as a speed governor
Mm-hmm.
on growth of cells in the body. And then the question becomes, well, how do you know which speed to set this at? Does my patient need to be set at 35 miles an hour?
Mm-hmm.
Do they need to be set at 50 miles an hour? Do they need to be set at 5 miles an hour? How do I do the dose finding? Right? So it's just this beautiful, logical drug. Everybody who's working with it goes, oh, this makes perfect sense. This is obviously a great drug in general. But how do we go from generalities to the individual patient?
Mm-hmm.
And who takes the risk? And who pays for it? Right? And I think this is the frustration that
Yeah.
many patients are expressing to me, and I think many physicians express, which is, wow, this is a beautiful tool, but no one's coming to save me.
Mm-hmm.
No one's giving me guidelines that are credible. I read stuff on listservs, or I read papers, and there's a certain superficiality to these discussions because, oh, we've looked at rapamycin and treating psoriasis. Well, hey, 99.9% of my patients don't have psoriasis.
Yeah.
What about those people? What's
Yeah.
close for that group of people? Or, I think Wisconsin now has a couple of rapamycin trials for Alzheimer's prevention.
Interesting.
Well, how far along,
Yeah.
right? How far along are these Alzheimer's patients? And what dose are they using for these Alzheimer's patients? And, how long do they need to be on RAPA before they prevent Alzheimer's? I mean, it sounds like it's a really simple study to do, but, the more you think about this intersectionality, how people are not just one disease. They're an intersection of all of these, sort of competing trade-off phenomena. It becomes clear. It's like, oh, we need to look at this in a different way. Kind of have a patient walk in your office and say, hey, if I give you 1 milligram of rapamycin, you have a 50% probability that you're going to feel better, and you have a 2% probability you're going to get a side effect. We're not going to get that by doing these piecemeal little studies.
Yeah.
And
Yeah.
so who pays for this? How do we move forward? This is
Great.
the challenge of the age.
Yep. 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 I'm just going to grab my water. I'm going to close my video 1 second. Okay, I'm back. Sorry about that.
No problem.
So where do we go from there?
How do we eavesdrop on the conversation?
or how do how do we use rapamycin? What are we looking for? How do we eavesdrop on the cells? What kind of changes can we anticipate?
I think you and I were talking about this before, which is, it's not enough to come up with pretty words, right? We're going back to this interest, the Newtonian physics versus the
Mhm.
quantum, right? You come up with an idea and then you invent a technology to help you refine the idea, right? So I think there's a couple of things that patients are worth thinking about, which is the value of perturbation studies. I think we haven't spent enough time thinking about this
Mhm.
as practitioners. right? So if you give one of your patients 40 milligrams of prednisone in the morning, 40, 30, 20, 10, you do this all the time, right?
Hmm.
Someone comes back and says, my inflammation's a lot better, but I was crazy. I mean,
Yeah.
I was up all night, yelling at my family, right? As a psychiatrist, I can tell you with 100% certainty that person has some degree of bipolar disorder.
Really?
Okay? Some degree.
I did not know that. Interesting. Uh-huh.
Well, I mean, it's very much like you would do if you had some gal who was pregnant, right? And you worried whether she was going to have pregnancy-induced gestational diabetes. You do a glucose tolerance test,
Oh, yeah.
right? You do a challenge, right? You
Uh-huh.
worry about whether somebody has cardiac disease. You put them on a treadmill and you look for ST changes.
Yeah.
I think psychiatry has, for whatever reason, formally not thought carefully about the value of challenge studies. You know, informally, we do it all the time, right? If you show up in my office and you say, "Hey, I've taken 2 SSRIs and I go crazy each time," everybody knows you have some form of bipolar disorder.
Hmm.
How much, it doesn't matter, but it's like that's obvious, right?
Hmm.
Let's say you give a young child Adderall for ADHD, and within a few days he becomes angry and paranoid. I mean, as a pediatrician, you're going to tell the parents, you're going to say, "Look, I can't say for sure this kid's going to have schizophrenia, but this isn't the typical response to Adderall."
Hmm.
And we know that 1% of the population is going to develop the post-schizophrenia syndrome.
Hmm.
Does the challenge study tell you that at a minimum, this child is at risk for psychosis? Right? I think that's obvious, right?
Hmm.
And, is there a way to do psychiatric diagnosis where we come up with very subtle listening devices to these conversations, right? And push the system with one of these master control drugs. Like, we give someone 2 milligrams of rapamycin for a week.
Hmm.
That's not a lot of risk.
Hmm.
Look at pre and post, and does that tell us important things?
Hmm.
Do we give patients 20 milligrams of prednisone for a week? Do we give, there's all sorts of like theoretical things we can do that because there's no pharmaceutical companies paying for this,
Hmm.
and because the academics are so risk averse, they would never do this without 2 years of an IRB.
Yeah.
Right? I mean, it's just the academics, the universities aren't here to save us. They don't care about patients at all. Just the people out there don't realize they have no interest in patient care, zero. This is about, do I get my junior faculty appointment? Do I get my grant? Do I get published? I wish it weren't that way, but that's the brutal reality, like gravity.
Yeah.
But should we think about the meaning of a bad medication reaction? In other words, the zen or the paradox of a medication reaction. If you have a bad medication reaction, that's really important. That's a victory. It's telling us something.
You get a lot of information. And I often will say to patients, like, this is not just for, patients will say, oh, I don't want to take that pharmaceutical. And I'll say, well, it's part of our diagnostic trial. Like, it's going to tell us,
It tells us something.
it tells us something. Yep.
Absolutely. 100%.
Yep.
Right. And I think I wish there was a way to get more kind of structured attention on side effect rather than just on benefit.
Yes, I agree.
Right. That we should look at what happens when we push the system and measure the perturbation more carefully.
Mhm.
That's low technology. That's not complicated. We don't have to invent very much of a technology.
Mhm.
Now, the other thing that we're looking at lately, and we have other things we're looking at, but there's a company that is doing RNA analysis where they'll generate a vector of 400 to 500 RNA species within the cell.
Mm-hmm.
And you're literally measuring now to some degree, you're not measuring the communication between cells, but you're measuring a different communication, which is the communication between the extracellular membrane, the outside world, and the nucleus.
Mm-hmm.
Right? And that's not just one thing, that's a whole bunch of things that are all happening all at the same time that are competing against each other.
Right.
Right? They compete too, right? There's
Right.
competition within the
Right.
cell, right? So you can't understand it just by measuring one thing within the cell. You have to measure all of it all at once.
Mm-hmm.
Right? And I love this concept that the cell has a consciousness. And of course, that's correct, right? It's its own kind of consciousness. It may not be an electrical consciousness, but it's a biochemical consciousness.
Yeah.
So are we measuring the cell's consciousness by measuring everything all at once?
Mm-hmm.
That's a very promising technology. And we're trying to get some experience with it and understand the cost benefit of this.
What is that? Can you talk a little bit more about what that technology is, or does it have a name? Like if people are curious to look that up more.
Okay, so what's happened, we should finish up quickly, but I think it was Rosalind Franklin. I think it's Rosalind Franklin was giving a talk at the aging conference in May in Alaska this year.
Mm-hmm.
She's giving the emeritus talk.
Mm-hmm.
She says, it's just amazing to see now what technology allows us to do.
Oh yeah.
She says, I can take, in the old days, if I was interested in a protein, it would take me, a week to do the assays and measure the level of the protein.
Mm-hmm.
Because now everything's automated. I can measure 10,000 RNA species and 10,000 cells within a day.
Yeah, it's crazy.
Within a day,
Yep.
right? And so, the DNA just sits there. It doesn't do anything. It's coiled up in a stem cell and it's protected against oxidative damage by histones that keep it coiled up tightly. And then it gets a signal from the environment that says it's time to unwind. The DNA unwinds. And some of that DNA is transcribed and some of it is left alone. And so a measurement of what the DNA is hearing from the external environment is the RNA that is being
Yeah.
expressed uniquely within every cell in the body. Each cell has its own consciousness, right?
Mm-hmm.
And that pattern of expression is the communication between the external environment and the DNA.
Mm-hmm.
So you can look at that unique pattern in the blood in living cells and try to understand each person's personal code.
Mm-hmm.
There are similarities and there are differences, right? We all came out of Africa, so it's going to be similar, right? And yet we're all quite different, so it's going to be different. And it's that what it does is it allows you to place your patient in a location in a multivariate biochemical space.
Yes.
So you don't give them a diagnosis. You're not giving them a 1 or a 0. You're not throwing away information, right?
Mm-hmm.
The amount of information in a diagnosis is 1 or 0,
Mm-hmm.
1 bit, right?
Mm-hmm.
So you cannot get dumber
Mm-hmm.
by giving someone a diagnosis. You're basically saying, I want to be dumb.
Yeah. Yes.
You've compressed your consciousness into 1 bit of information.
Yes.
Right? Whereas with this sort of technology, you have to think in a vector space. A patient
Yeah.
is in a location. They're not in a diagnosis. And
I mean,
that goes back to the concept of intersectionality, right? It's a
yeah.
way to force yourself to think in intersectionality.
Yes. And in patterns. Yeah. Fascinating. Fascinating. How are you kind of like, how do you take these concepts to how you treat patients? Like when you listen to a patient talk about their symptoms, how do you apply this like approach or this understanding, how do you apply these insights?
Well, right, I can't simplify that. I mean, at least not very easily.
I was worried you would say that.
Well, I mean, like again, it's jazz.
Uh-huh. Mm-hmm.
You're looking at a lot of things all at once,
Mm-hmm.
right? And so you say, well, what was the one thing that told you I had psychosis? It wasn't one thing.
Mm-hmm.
It was all of it, right? And you don't want me to tell you that's one thing,
Mm-hmm.
right? Because it's telling you that I'm simplifying things, and biology isn't simple. It's never simple.
Mm-hmm. Fair enough.
Got it. Okay, I got to run.
Perfect. All right. Well, this has been an awesome conversation, and I'm so glad that you took some time with us today. We really appreciate it. It's a fascinating outlook from a psychiatrist. And we love that you've joined us today to discuss how to make our whole world medicine. We rise or fall together and are committed to sharing knowledge and insight that empower us and our communities towards greater health. Thank you for listening to the Neuroveda podcast for complex health, and we'll see you next time.